Now then, let's move up to pontine lesions, starting with medial pontine syndrome. And again, here is the lesion site indicated by the area in green on the medial and caudal pons. So this is the result of involvement of some of the paramedian branches of the basilar artery, which we know are our medial pons blood supply. So again, look at the tracts that are involved. Any medial vascular syndrome is going to involve the corticospinal tract, but since it is still in a medial vascular territory, the lesion also involves the medial lemniscus. So our tract signs are going to be exactly the same as those we saw in medial medullary syndrome. We're going to have contralateral limb and trunk spastic weakness and contralateral loss of touch, vibration, pressure, and proprioception. But what localizes the lesion? What cranial nerve, which we see right here, is going out and exiting from the medial and caudal pons at the pons medulla junction? The fibers of the abducens nerve. So this patient is not going to have tongue weakness. They're going to have ocular weakness. And if you lesion the cranial nerve 6, the patient will not be able to abduct their eye on the side of the lesion, and the eye will be deviated medially or internally by the unopposed action of third nerve adductors, and this patient will have a medial or internal strabismus. So again, this is just like medial medullary syndrome in that the same tracts have been lesioned, but it is localized very precisely by a different cranial nerve, the lesion of the fibers of 6, giving us an ipsilateral abducens nerve effect. Then, what is going to be different about a lateral pons lesion? Look in the same slide, but now we're looking at a lateral and caudal pons territory. And this area is in the vascular territory of AICA, the anterior inferior cerebellar artery that's perfusing the lateral and caudal aspect of the pons. So in a way, this lesion is going to be similar to lateral medullary lesions in that the tract signs are going to be similar. Let's document the entire list that's shown on here. So first off, we know that the lateral coursing tract is going to be situated out here, and that's going to be the spinothalamic tract. That again is going to give us a loss of pain and temperature in the contralateral limbs and trunk. But now, in addition to that, the patient is likely to have ipsilateral central Horner syndrome because we know those descending hypothalamic axons are there. But what cranial nerve is coming in or out of the lateral and caudal pons instead of 9 and 10 from the medulla? Now we are looking at a complete lesion, hypothetically, of the facial nerve. So instead of having palate weakness, dysphagia, and hoarseness, the patient's going to have facial paralysis and probably all of the other signs and symptoms of a complete facial nerve lesion, including ipsilateral facial weakness, loss of taste from the ipsilateral tongue, a dry eye, and loss of the corneal blink reflex and hyperacusis as a result. Note also, because the cochlear nerve fibers tend to enter more at caudal pons than upper medulla, this patient is also very likely to have an ipsilateral sensory neural hearing loss because the lesion has probably involved either the entering cochlear nerve fibers or the cochlear nucleus. But then, similar features. The spinal trigeminal nucleus is still in this area, so the patient again is going to have our dissociated pain and temperature loss, ipsilateral face versus contralateral body. And again, the vestibular nuclei might be involved, causing vertigo, nausea, vomiting, and the nystagmus. But now, the middle cerebellar peduncle is responsible it's situated up here and not really illustrated on here. If lesioned, it might cause, again, an ipsilateral ataxia because the pontine nucleus axons that are sending a copy of the motor plan into the cerebellum might also be lesioned, causing the ipsilateral gait ataxia as well. So again, what's similar? This lateral pontine lesion has lesioned the same tract of axons that we saw in lateral medullary lesion, but it's been localized by different cranial nerve. The facial nerve and the cochlear nerve in lateral and caudal pons versus the involvement of cranial nerves 9 and 10 in a lesion of the lateral medulla. Now then, one last comment to be made, and that is, what if we have a lesion that is situated outside the pons in what we call the pontocerebellar angle, and this lesion is usually directly the result of a slowly developing benign tumor known as an acoustic schwannoma. And the acoustic schwannoma develops slowly in the Schwann cells of the eighth nerve, but it has to develop in the Schwann cells of the eighth nerve outside of the brainstem. So it's going to be positioned about there. So what's going to tell us, basically, that this lesion is not inside the brainstem? Well, number one, it's a slow-growing event, whereas brainstem vascular syndromes tend to bring on an acute onset of neurologic signs and symptoms. As the tumor grows, it tends to put pressure on the caudal pons, where the adjacent eighth nerve is also commonly going to be compressed. So again, this patient is likely to develop Bell's palsy and all of the signs and symptoms of a complete facial nerve lesion. So certainly the cranial nerve deficits will localize the lesion source to something that's involving both cranial nerves 7 and 8. But the absence of the long tract signs mean that the lesion that involves only 7 and 8 has to occur outside of the brainstem. And this is certainly indicated by the presence of a schwannoma, which is only myelinating peripheral nerves outside of the central nervous system. So this is pontocerebellar angle syndrome. It is also a lesion involving cranial nerves 7 and 8, but we don't have any of the spinothalamic tract involvement, no Horner syndrome, because the lesion is occurring outside of the brainstem.